So that's just an aside there. I'll wait till it's a little bit more kind of medium length of time frame.
Yeah, and it's like medication. I mean, there's dosing as far as everything that you're doing. I mean, you can be aggressive with cupping, you can be aggressive with instrument assisted, you can be aggressive with dry needling, you can be aggressive with an exercise loading someone. So just figuring out what dosage is currently useful for someone is, I think, the most important part when you're starting a relationship with someone and trying to understand, you know, how to best help them out, is just, you know, what in fact amount of dosage can you give them, and then dose it up as you're able to, and dose away some of the passive treatments eventually over time too. But that's why I tend to usually favor cupping first, just because it's a little bit less aggressive than dry needling. So I do dry needling too. But if they get a good response from cupping, it's simple, it's quick, and then you can move on to more effective things in the long term, which would be a loading program if you do get a response. But let's say you do choose to use dry needling. How would you go about doing that, Eric? Are you hooking, are you just working the gastroc soleus? Are you going down around the Achilles, 𝐸-stem? What would you start, say, first day with someone who is in more of a reactive state, or potentially when you first start utilizing dry needling?
I found definitely I'll target that medial gastroc, and then I always typically, if the issue is in the Achilles, I'll usually go down to the Achilles. There is some, depending on what your beliefs are and where were trained after needling, they'll say that you can actually do a little bit of pecking, like periosteal pecking on the bone at the insertion. That is not one I would do in the acute phase. So if you're looking to cause a traumatic little experience there at that insertion, that's definitely going to be, though, indicated with your chronic. So if you have somebody first day, you need to assess, are they in reactive or is it long-term chronic? And then I would start a little bit more simple. So I may do 2 needles in the gastroc, hook it up to electric stim, and then I may do 2 on each side of the Achilles and hook those up across the Achilles to stim. So again, you're just trying to alter their perception of pain. Maybe you could increase a little bit of that microvascularization around the tendon, which the tendons aren't super vascular anyway. But if you're just trying to promote a healing process, and then you could dose up from there. So I would say the max I would do is maybe 3 or 4 across each side of the tendon, so 6 total, and then 2 in the medial gastroc. And I'm always using stim in those areas personally.
Okay. Does that change as far as if it's insertional or more mid Achilles, as far as the location of where they're experiencing pain?
Yeah, that's a good question. Yeah, I'll definitely take that into consideration. Although I will say, if it's regardless of whether it's insertional or whether it's like mid Achilles, I'll always do the gastroc, because I feel like that always has a component, whether it's no matter where it's at in the tendon. So based off tendon location, I may alter my position of the needling in the tendon itself or at the insertion, but then I'll also always do that the gastroc.
Okay. Yeah, so I mean, there's kind of just a manual therapy gist, and again, for those of you who are on the call, if you have a question about any type of manual therapy intervention, we'd like to, you know, have you jump in and just weigh with some of your questions. All you got to do is hit the unmute button, and then you can jump in. Love to hear some of your thoughts too, but we'll start getting into some other things that we're looking at, because again, we're not trying to focus just on manual therapy with these individuals, or really any individual. We're trying to get them back to some type of loading and physical activity. So just some general things that I'm looking at in assessment as far as just observational is definitely looking at shoes and what type of footwear they have. Now, everybody may not be willing to change their shoe type, or they may have just bought shoes, and there may be potentially a socio-economical situation there where they may not have the money to afford new shoes too. But looking to see how somebody loads their foot and the pattern that they load their foot with shoes on and with shoes off is telling for you too. So with the shoes on, a lot of times you'll see people who kind of glide to the outer portion of their shoe, and you'll see the lateral portion of the heel have a lot of wear, as well as in the forefoot. You'll start even seeing some of the shoes now don't have a really exceptional toe box, so the fabric in the lateral portion of the shoes is weak, and you'll see some fraying of the fabric of the shoes too. And just someone who is shifted over in the lateral portion of their shoe, that's going to put one wear pattern on the Achilles. It's it's more of a supination, supination moment there. And then you'll see other individuals who are more pronated as well too, but realizing that those two positions impact the amount of torque that's placed on the tendon, and that could change depending on, you know, barefoot to footwear. So a lot of times people recognize that footwear is going to be implicated as far as, you know, how their tendon feels. So they go and search out a shoe fitting store or something of that nature. So they may be put in a shoe that potentially exaggerates the opposite of what they're normally used to. So I've seen individuals who have pronated feet, barefoot, and, you know, have quite a bit of, you know, they'd be considered flat-footed, but they present more pronated. And then when you put them in their shoe stacks them up so high that now they start to invert their foot a little bit, and they go so far in the opposite extreme that potentially causes the problems too. And, you know, they'll tell me that this footwear they got the shoe 2 months ago, didn't have pain 2 months ago, then all of a sudden it popped up, you know, last month. And they're not really thinking it was caused by the shoe because the time frame doesn't necessarily add up, but those type of things tend to take a little bit of time to present themselves, but definitely have implications for people as far as chronic wear patterns of their shoe, new shoes that they choose. And the other thing too is people will go to extremes with the amount of heel drop that's in their shoe too. So avoiding any type of extreme changes, I think is important for someone who has been dealing with Achilles injury. Figure out if there has been a large change in their foot position in their shoe. Is that causing more of a problem, or is that helping the situation? Or someone who has had, you know, long-standing Achilles problems, maybe they've just never been in the right footwear to begin with too. Anything you got to add to that, Eric?
No, I'm gonna be honest. You're the man on footwear. That is not my specialty.
So, but yeah, that's the bit. Just looking at the shoes, and then looking at someone without the shoes too, it tells you different stories. And someone may have gone to someone else who recommended a different shoe, and it doesn't necessarily mean that shoe is optimal for someone too. There's all sorts of opinions out there with it. So again, just like manual therapy, you got to find what's best for them. You got to ask them some questions about the shoes and how much they like the shoe, how much it feels good, and then go back into a little bit of a history as far as, you know, how that could be playing a role with their symptoms. Obviously, if someone is in the acute stage, more dorsiflexion does hurt. So giving someone heel lifts is helpful in raising the heel up at acute times in the situation to take some of that compression off of that tendon. And as the tibia glides forward, it puts more compression at the insertion point. So oftentimes with insertional Achilles tendinopathies, that works well for some people. Yeah. So
I will, real quick, I'm just going to tangent off on that. I'm just going to give an analogy. I do assess footwear. A lot of times, though, if they have other deficits, I will, and obviously I know you would too, I'll definitely have them address those necessarily if their shoes don't look too bad. I like to compare it to somebody who says that they have back pain and they just bought a new belt. So they have a brand new weightlifting belt and they're squatting and they have no bracing. They have terrible form. They're just a disaster. Just because they have a new belt, aka new shoes, there's a lot more going on internally that needs addressed than the fact that it's not that the belt is dysfunctional, it's that their movements or their strength or their stability is dysfunctional. So not the shoes shouldn't be addressed for sure, but I feel like if you have somebody who's reluctant to buy shoes, sometimes you can take that internal approach of what they're doing wrong.
Yeah. Then, I mean, the next part is the loading of the injury. I mean, you got to get to loading at some point in time. The easiest way that I've found to load somebody is with an assisted heel raise. So someone can easily stand in a doorway or by the parallel bars on flat level ground, and they can use their hands to offload their body weight as much as they need to help push them up and help control the eccentric lowering too. So again, depending on comorbidities, the acuteness of the situation, how much pain, some type of simple assisted loading where they can use their hands to help push them up gets them doing something. And that's usually the very first point of entry that I'll do with somebody. But again, there's a continuum there as far as how aggressive you can go, and we want to try to push them further along the continuum as it tolerates, and as they're able to load the tendon within comfort. There's going to be some discomfort with the heel raise, more than likely, and especially the eccentric component. A good sign is if, as they perform the reps, it actually feels more comfortable as they do more. The first 5 reps may not be the most comfortable, but as they get towards 8 to 12, working towards 15, it may feel like it's loosening up a little bit. And as you encourage some movement, then things start to improve. So some of the suggestions that I would have would be starting with that assisted version for someone who has very limited loading, and then moving towards the unassisted, or just kind of hands there for balancing, going up 2 foot bilateral, and then really slowly eccentrically lowering on the way down, almost like a 4-second count. So really exaggerating it. Now, depending on if it's insertional or mid Achilles, you're going to choose flat ground or on a step. So insertional, you don't want to increase the amount of dorsiflexion. You're going to stop at neutral, again, just because of the compression that happens right at the calcaneus there, the assertion. So you're going to be on flat ground, and then you're going to progress someone with a mid belly Achilles. There's not as much compression going on to the spot of injury, so you can start to you can start to put them into a little bit of dorsiflexion and get them to get into a little bit more stretch. But oftentimes I'm really not stretching these situations. I'm trying to figure out where I can load them and then progress them from there. So the bilateral assisted, then moving towards unilateral, where they go up with 2, down with 1, and that can be assisted as well too. So they could go up with 2 maybe now without an issue, and then the eccentric lowering. In order to get that 4 seconds, they have to have some assist for control. So they use their hands there again to help control them on the way down. And again, the depth is dependent on where the injury is at. If it's insertional, you're stopping at flat ground. If it's more mid Achilles, then you can start going into a little bit of dorsiflexion. So that would be the progression. Then eventually getting to no assist at all with your hands. The hands are just there for balance. I'm really not concerned about balance at all with these. I'm just concerned about loading the tissue, so they can put their hands on a wall, do whatever to keep their balance there. And then you're thinking about starting to add some loads. So I have a lot of clients who go up to 40 pounds just holding it in one of their hands, the side that you're working, going up with 2, down with 1, and with that slow lowering and doing upwards of 15 reps. And then trying to repeat that some way at home, whether they have weights at home or if they have a backpack and just throw some books in there too. But just trying to do that. So there's the knee straight version, and then there's the knee bent version. So you get both the gastroc and soleus. So going up with the knees straight, and then going down with the knees staying straight. There's your gastroc. Going up with the knee straight, and then as you lower down, you let the knee bend forward into, say, like a terrible squat position, where the heel stays on. Eventually, when your heel drops to the ground, your heel is down, but your knee is driving forward over top of the toes into like a soleus stretch position, and then straightening the knees back out, then rising back up into your heel raise, and then eccentrically lowering back down into that dorsiflex position in the closed chain. That making sense there as far as what I'm doing, Eric?
Yeah. Yep. I agree.
Okay. I think I'm describing. If you have questions with that heel raise as far as what it looks like, again, it's on the previous couple posts that we did this week, but that soleus version where the knees are bent, that one's a little bit more aggressive. So that sometimes you can be a little bit more aggressive with the knee straight version, and then you have to be using more assist or less weight with the knees bent version. There are situations where it's vice versa, but just considering that is helpful. The other thing that I've been doing a little bit more and more of is, and this isn't necessarily in any type of research articles, but if you familiar with any type of tendon loading, it's got the eccentric phase, it's got the isometric phase, and it's got concentric phase. So finding different ways to isometrically load the Achilles is something that you can usually do early on too. And ways that I've done that is if you got a high-level athlete, you can put them in a squat rack with the pins on the top portion of it, and then put a barbell on their back, and then they do a heel raise up, and then the J hooks stop you from going any higher, and then you can isometrically be pushing into that J hook to be to loading it and ramping it to your intensity, trying to get to upwards of 100% kind of pressure, trying to heel raise upwards. So what I've done there is go ahead.
I was just gonna say they're starting to really hammer out the lower extremity research with isometrics. As far as good studies like on basketball players in season doing knee extension isometrics for 45-second holds in order to reduce pain, not for strengthening, just to reduce pain. So I think Achilles is much the same way. Any of your load-bearing joints, those tendons doing isometrics really seem to respond well. The longer the hold, not our typical, like you may do in the clinic where you do a 5-second, 10-second hold, but progressing up to like 30-second holds of isometrics for pain, some analgesic.
Yeah. So it's definitely the research is there is in other parts. I don't know if I've necessarily seen much in the Achilles, but so that's where I'm just trying to apply some different research to the Achilles there. So that pressing up in the barbell and doing it at different angles, a lot of times, again, the more you go into dorsiflexion, the more provocative it is. So if it's really uncomfortable, if they're able to get up high, they can actually put a little bit more force into the isometric. If they're down low and they're, say, in the neutral position, they're probably not going to be able to tolerate as much pressure upwards. And then, again, if it's more of mid-Achilles where potentially you have someone dropping off the step and you're getting off of that very bottom position and more of that dorsiflexed position and performing your isometric there, that one's usually even more sensitive. So you got to be careful. And again, you're just ramping it to their intensity so they could be performing that, say, at 40% effort. But eventually you're trying to get up to about 100% effort doing it for something like 10 seconds. I think for the knee research, it's a little bit longer than that, getting towards like 30 seconds, but the gastroc a fast twitch muscle, so it's going to fatigue a lot sooner. It's a smaller muscle, so I usually go with lesser time. 10 seconds is probably about the max that I do with someone there. We do, so we're running here close to 1 o'clock. I want to try to keep these short and kind of takeaways for you that you can take back to the clinic, because again, we're going to be doing these weekly. So I don't want to make them too long. I know it's your days in the middle of your day. So we're going to wrap up here real soon. As more people start joining these calls, we may start to extend this out longer. And again, as far as the benefit that you have from this, I'd much rather be talking about what you want to talk about. Me and Eric can sit here and ramble back and forth about things that we want all the different times, and we'll certainly do that. But we're trying to get more into what's pertinent to you, how this can be useful, applicable to you. So just more people that join in on this call, join the conversation. We want them asking questions. It doesn't have to be related to what we're planning on talking about. Let's talk about what you want to hear, and that way you can get more out of this. So we're going to keep doing this weekly. It'll keep building from here. Sorry for a little bit of the trouble early on with some of the technical difficulties. That'll be, hopefully we get that washed out real soon. My computer was just freezing. So it shouldn't be any big issue, but we'll be back here later on talking about more things. There's going to always be an option to submit questions too. So if you don't want to come in and ask your questions, if you just want to listen, at least submit a question beforehand so we can start talking about some of these things, and we can go from there. All right. Thanks for everybody who's joined the call. Erica, thanks for being here. I know you're listening in the background there. And then, like I said, too, you can join from your phone too. So we have someone from the phone just kind of listening in too. So depending on what you're doing throughout the day, you can always tune in. I'm going to send a replay out to the email list tomorrow, and so you'll have access to this for future as well too. All right. So everybody take care. Have a good one.